and PT treatment strategies. All right, we'll start with the effects of behavior and health. So, health is influenced by factors in 5 domains. Now, that is in genetics, social circumstances, environmental exposures, behavioral patterns, and healthcare. Now, this has been a controversy ever since. Now, as you can see, this is a pie chart wherein we could see that majority of the contribution of premature death is related to the behavioral patterns of our clients or our patients. Although genetic predisposition, social circumstances, environmental exposure, and healthcare also plays a role, but then the biggest bulk would be seen in the behavioral patterns of each individual. Now let us define what is behavior. To begin with, behavior consists of an organism's external reaction to its environment. Behavior is learned and or maintained by consequences it produces in the environment. Meaning behavior is not permanent. It could be changed, it could be shaped into a better one. Now, when we understand behavior, we want to put in mind that then again, behavior is learned and it's not innate, meaning nobody is born as he is. Now, it is maintained and shaped by reinforcements and or punishment. It can be taught, changed, or modified, and the key to modify and change this behavior is to understand the aspect of the behavior. Why is this person acting the way he or she is? Now, behavior is observable and measurable at the same time, meaning we can derive data from this in order to systematically analyze everything. Now, we have 2 functions of behavior. Mainly, this means that a person acts the way he or she is in order just to get something or to avoid or escape something. Given, for example, you go to class in order for you to get a degree. So that's a behavior. You avoid a thief because you run away from a thief but you want to avoid them. So this is a simple example for the functions of behavior. Again, a person acts the way he or she is just in order to get something or to avoid something. I know that you are pretty aware about this diagram. It is your biopsychosocial model. This model has been proposed since the 1990s until the 1999, I think, or 1998. This diagram says that in order to cater our client's need or our patient's need, we need to see the biological, psychological, social environment, and the mental health of our patient. But then, as the years pass by, we have a new model, which is your biopsychosocial ecological model. Now, this has been proposed in the 2000s until now. Now, what is the difference of this model? Now, what they did was they dissected each and every aspect into 4 things. That would be first your intrapersonal, meaning it is in the self level. It pertains to your knowledge, your skills, your self-confidence, perception, motivation. Next would be your interpersonal. Do you have a social support? Do you have time constraints in your environment? Next would be your community and institution. This would be the schools, the environment, the parks, whatever that has to do with the environment that would be into community and institution. And next would be your public policy, which means it goes into your media advertisement, development regulations, and public policy. So what is the importance in learning all of these 4 things? According to your biopsychosocial ecological model, they said in order for you to change a person, or in order for you to have an impact to a client or a patient, you need to target at least 3 of those domains. Meaning you can't just go by 1, you can't just go by 2, unlike your biopsychosocial model. Now with this social ecological model, if you target 3 of these aspects, then you can change a behavior pattern into your client, hence having a bigger impact to their health being. This is what you call your fear avoidance model. And this is very common in people who are experiencing chronic pain. Now, with this, we can see that we have different types of behavior seen in each patient. We have what you call your catastrophizing behavior. Now, this type of behavior is taking a relatively minor negative event into a social disaster. For example, when a client or a patient says that they're afraid to walk outside again because of their surgery, because they might fall again, and then when they fall again, this could happen, and so on and so on, that would be a catastrophizing behavior. Next would be your avoidance behavior. An avoidance behavior is just typically avoiding something to be comfortable in your current position. So avoiding situations that are uncomfortable or provoke anxiety. Next would be your safety behavior. A safety behavior are the actions that people take to prevent their feared catastrophes. Now, I want you to take note about the difference of an avoidance and a safety behavior. When we talk about avoidance, you're avoiding something that can bring you harm. All right? While in safety, you keep into your inner circle to prevent yourself from being exposed to the threat. So that's the difference. And these two things leads to what you call your kinesiophobia. And kinesiophobia is the fear that moving might cause pain. And if your patients or clients fall into kinesiophobia, they would have their activity limitation. And it would go into another cycle of fear avoidance, causing more pain and not treating anything. Now let's move on into applied behavior analysis. What is the importance of learning this, and how could we integrate this into our practice? Now, applied behavioral analysis, or also known as your ABA therapy, is the science in which tactics are derived from a principles of behavior. Mainly, ABA is wherein you dissect each and every component of a behavior in order to systematically strategize a plan to target each of these things for you to create a new behavior. Now, what happens with this is we jot down what happens before, during, or after a scenario. We have what you call your three-term contingency. And when we talk about the three-term contingencies, this is just a dissection of the behavior. What happens before, what happens during, and what happens after. To give you an example, so this is a common example that we get. When you go into a restaurant, let's say McDonald's, and you wanted to order a burger. What happens before you order a burger? And that is what you call your antecedent. Now, the cashier asks you, can I take your order? Now, this is your cue now on saying, yes, I would like a hamburger and fries. Now, after this, what would you get? When you say you want a hamburger and fries, they would give you a hamburger and fries. Hence, now you know that whenever you say this word, you'll get the item that you want. Now, another example is if you are walking into a university and someone calls your name. If you don't want to answer that person, you just walk away. And whenever you walk away, that person stops calling you. Now, this would be a repeated behavior. Now you know that whenever you walk away with someone, from someone, that someone will stop calling you. Now, this is how we want to integrate it now into our practice. Now, another aspect, and this is where we physical therapists really plays a big role. This is what we call your motivating operation. When we talk about motivating operations, this has something to do with the environment of our clients or the environment where our patients work in. Now, you want to create a stimulus change into the environment to reinforce them into doing something. For example, if you want your client to start going into exercise and an exercise daily routine, you wouldn't put them into a sleeping room or into a bedroom, right? So you want to change the environment. You put them into the environment that would make them be more motivated. Given, for example, if we will go and target the social ecological model and try to target three parts from it, first is you want to educate them with it, and that would go to your interpersonal. And then you put them into a community or into a society. You give them the interpersonal aspect. And next, with the community and institutional, that is where you change the environment itself. You put them into the scenario that they would be motivated or there are no other chances for them to do anything else. So if you put them or enroll them into a class and they arrive, what happens? They go into a class. They start exercising. So this is mainly what motivating operation is. It's just changing the environment in order to motivate your patient into the behavior you want them to have. Another is your reinforcement or punishment. This is mainly used with pediatrics, but in ABA, we can apply this also with our adult patients. Now, put in mind that reinforcement are something that increases or maintains a behavior, while punishment is something that decreases the behavior. Now, it could be placed into a positive, into a negative aspect. We call something a positive reinforcement if you add a pleasant stimulus to the patient. For example, if the patient keeps on working out for 3 months and gains an ab or loses weight, that is a positive reinforcement because what? They have now a pleasant stimuli presented to them. They get what they want. Now, what is a negative reinforcement? A negative reinforcement is when your patient exercises and loses weight. What happens? You remove what they want, what they don't want, right? So that is the negative reinforcement. One is being removed, but still reinforcing exercise, and one is being added, but still reinforcing exercise. Next would be your punishment, and we don't really use punishment. Example of punishment would be whenever a military person gets late and you ask them to do 20 push-ups. So that's typically what a punishment is. Now, let us put everything into a case. Now, we have your Threeterm Contingency again. I want you to remember your antecedent, your behavior, and your consequence. If you have a patient complaining with low back pain for 3 months and comes into your clinic complaining of back pain after he gardens his plants, he reported having 2 weeks of sessions already of PT, but then the pain still comes back. Now, you know, as a physiotherapist, you already done your part. You're giving your exercises, you've already done all of the treatment that you know, but when he comes back, there's still pain. Now you start to wonder, does this patient do their home exercise program? Should I change something into his daily activities? So after further assessment, you found out that this is how he does his gardening. And we all know that this posture really provokes back pain. Now, in a physiotherapy mind, we want to fix the ergonomics, right? That is correct. There's nothing wrong in fixing the ergonomics. But the thing is that there are times that the patient tells you, it can't be helped. This is the only way that I can do it. I don't know how to change it. Now, if you will apply behavioral analysis here, this is how we will see it. First, you check the antecedent. Why is the patient bending down while getting the vines? It's because it's a low-grade vine tree. Now, can you do something about the tree? No, you can't make the tree go higher, right? Now, if the tree is lower, what is the behavior of the patient? He leans down, bends the back when picking the grapes. Can you change this? Yes, you can. Now, but what do we want to happen? Why does he keep on doing this thing? He keeps on bending his back when picking the grapes because he gets the grapes easily at this time. Now, as a physiotherapist, we want to change this thing. And we will target now a motivating operation. We will try to change the environment. You provide them a low stool so that when they're picking, they'll sit down and pick. Or you provide them vine clippers so that they don't need to bend down and pick it from the shrub itself. Now, how can you again go back to your social ecological model and target 3 things here? First again is education. You tell them what is the pros and cons of doing this. Next is your motivating operation, your community. You give them things that could alter the environment, low tools, vine clippers, and so on. And next would be your policy. A policy is wherein you talk to the vineyard owners or tell them, give them an insight of what are the pros and cons and how you could help them have a better working environment. Next, This is what you call your Threeterm Contingency again, and it's to a shoulder impingement. A patient comes into you with left shoulder pain, and the patient states that she has been feeling the pain for 3 months and only uses her right arm when reaching something overhead. Now, is there something wrong with this? At the beginning, you may seem that, okay, it's painful, so she clearly won't use her left shoulder. But is this something good? Now, I want you to look into 3 months. The patient is already doing this for 3 months. And if she is doing this, it is already turning into a chronic pain. And she is now formulating a fear avoidance. Remember again, going back to the behavior, she is avoiding something. That's why she keeps on using her right arm, leaving her left arm immobile. Now, Threeterm again, the antecedent is trying to reach something overhead. What is the behavior? She uses the non-injured extremity in reaching. And the consequence is that she won't feel any pain on the left shoulder whenever she reaches. Now, I want you to look into how can you change this thing. Of course, then again, motivating operation. Educate them. Tell them that, okay, you can now move your arm and so on. So later we'll be discussing how you will properly change the behavior with this type of patient. And then this is like a quick cheat sheet. Whenever a pain, it is a movement-related pain, what happens is you're giving your patient a positive punishment. Meaning if you are doing a treatment and it causes pain whenever they move, you're only reinforcing them from stopping that movement. So you don't want to do this, okay? Next is being able to prevent the pain. And being able to prevent the pain is a reinforcer. But take note, being able to prevent the pain is just good during the acute stages of pain. Whenever it is already chronic, you want to make sure that they start moving their pain to get out of the fear avoidance cycle. Now, how is this being done? What are the strategies? First, in terms of your chronic pain, you should know the function of the behavior of the patient. Why is the patient doing it? Is she avoiding something or is she trying to get something from it? Analyze your ABC. Whenever you analyze, jot down what is happening before, what is happening during, and what is happening after. What does he or she get after doing this type of behavior? Next is use a cost-benefit analysis, and this is very important. When doing a cost-benefit analysis, you want to put into the patient's mind that, given, for example, healthcare or home exercise program, whenever the patient doesn't do home exercise program, you want to lay out to them the benefits of it and the cost of it. And when I say lay out to them, you just don't tell them. You write it down, you print it out, you give them a copy and show them, because a visual cue is always a better one. Now, after doing a cost-benefit analysis and making sure your client understood it, we go and use a graded hierarchy of fear or avoidance situations. Now, you want to jot down, after observing your patient, what are the things your patient is scared of doing? And you want now to put it into a hierarchy. What is the most one and what is the least? Now, if you have already jot down everything of it, you want now to use or create a behavior momentum. Now, what is a behavior momentum? This is where you shape your patient out of the pain or out of the cycle. First, you want to habituate and then desensitize. Now, when we talk about habituation, it is getting used into something. Now, when we do a behavior momentum for a patient, you want to make sure that the patient is getting used into something until the anxiety goes down. Given that it is pain, your patient is afraid to move. You want to make sure that the patient feels comfortable first with you, comfortable first with the actions or the movement or the objects that you're doing, until 50% of the anxiety goes down. And when 50% of the anxiety goes down, now you start to desensitize, meaning you expose them now. How is this being done? An ACL patient, a post-operational ACL patient, who has fear of still climbing the stairs. You start with step-ups. And if the patient is comfortable enough with the step-ups, you increase the steps. And then you expose them into the stairs. So this is how you would do it. Just put in mind, you habituate first, meaning make them comfortable, reduce their anxiety up to 50%, and then desensitize. Help them confront the fear that they're having. Next, you want to keep your exposure challenging but not overwhelming, meaning challenging enough for them to feel pain, challenging enough for them to feel motivated, but not overwhelming. Because sometimes things that are too overwhelming makes them feel demotivated. And this is also a part on how you should do your home exercise program in terms of applying ABA. So keep the exposure challenging but not overwhelming, just to make sure that the patient can do it at home. Now, these are your ABCs into treating these types of patients. To non-compliant patients, to patients who have pain, you want to understand their attitudes and their beliefs. What does the patient think to be the problem? Because at times, you and your patient have different goals. You want to make sure that you know what does the patient think to be the problem. Next, do they have a positive or a negative attitude toward pain and potential treatment? Is the patient motivated enough? Because if you will know if the patient is motivated enough or not, then you would play around. You would be able to play around on the motivating operations that you can do. Next is the behavior. Have they reduced their activity, or are they compensating for a certain convenience? Now, compensation is good in acute stages, but if it's seen in chronic stages, you might want to correct that. Now, compensation. Why are they doing this? Are they waiting for a claim due to a potential accident? Because in the United States, it is very common. They try to fake or lengthen their injuries to get a potential claim for them. Now, is this placing unnecessary stress on their life? Now, there are times that your patient wouldn't tell you, but we have psychological exams or psychological tests that physiotherapists could provide by giving the questionnaires, and from there you could deduce if these activities are doing unnecessary stress on their life. Now, diagnosis and treatment. Did they have this before? If your patient is diagnosed and treated with the same condition before, meaning they already formed a behavioral pattern from that condition, and they might changing their mind into being proactive during treatment might be quite challenging. So you want to make sure that you know if they have been diagnosed with the same or have the previous thing as well. Now, next would be emotions. Does the patient have an underlying emotional issue? Can your patient express themselves? Or are they just over-expressing themselves? Now, because this then again are used for behavioral change. In terms of family, now how are the patient's family reacting to their injury? This is very common with athletes whenever they get injured or post-operation surgery. The parents blame them and they say, see what happened to you, now we can do this, and why are you even doing therapy? Don't do that anymore. Don't believe this, just drink this. So these are like the patient's reaction to their injury. Some people just let patients drink herbal tea or ginger just to cure back pain or shoulder pain. And we want to make sure that the family is on the same side as you, because family influence plays a big role in the rehabilitation of your patients as well. Are they being under supportive or over supportive? Now, being under supportive is common also, but over supportive also harms. We have what we call the toxic positivity. And being into this toxic positivity, you are now disregarding the pain that the patient is feeling. And we don't want that to happen. Now, we don't want to discredit anything that the patient is feeling. Now, work. Are they currently off work? So, does the injury that they have impact their lives in this manner? Now, are they able to provide with their clients, with the other family, and so on? In terms of acute pain, we want to make sure that we use an antecedent intervention. Now, when we talk about antecedent intervention, it's meaning being proactive. You want to prevent it before it's happening, before it will happen. Now, this is an antecedent intervention. All right, so this is one of my favorite quotes, that people maintain unhealthful patterns of behavior because they focus on short-term benefits at that time. For example, your patient who picks up the vine, they take it because it's easily done, not thinking about what is the long-term effect. So however away from the immediate discomfort, the same may focus on wishing they were free from this restriction. Now, this is very common. Patients telling you that I just do this because it's the easiest way, but I hope that I can get out of this pain and I can do everything freely now. Now, as a physiotherapist, it is our responsibility to tell and shape our patients into the best that they can. And with this, if we already understand the behavioral patterns of our patients on what are they going to do and why are they doing these things, then we could create a better treatment program for them. So that is just for ABA and TB. So does anybody have any questions? Yeah? What is the best way to modify a behavior? Now, the best way to modify a behavior is to understand what is causing the behavior. Now, if you already know what causes the behavior of your patient, then from there we could start modifying. And you always start with shaping and behavior momentum. Now, it all boils down to analysis and learning first what is the problem and where does the problem come from. And from there, then we can do a treatment program for them.
If anyone else has some questions, they can either unmute themselves or can ask in chat box.
Having a left side paralysis, whenever he used to make him do exercise, he would say, it is paining, paining, paining. Okay, to begin with, if you have, now we want to understand what is the cause of the pain. If your patient has a left side paralysis, what are the things that goes in, first into your mind of causing the pain? Could it be a shoulder problem? It could be a frozen shoulder that is brought about by immobility. There are many things. Now, if the patient feels the pain, you want to start, again, habituate. Do an exercise that makes them comfortable with the movement. If the patient feels pain at 70 degrees or 90 degrees of what you call the shoulder flexion, you want to lower down first into a lower degree. And if they feel, oh, okay, this is not painful, and if you see that the anxiety drops down by 50%, then you increase and you increase and you increase. So that is where you do an habituation and desensitization at the same time. Patient, general, I have to say, modify behavior of my students. Okay. In general, if I have to say, modify the behavior of my students or my kids, then what you should suggest. Now, you cannot, there is no certain practice into changing a behavior because then again, we need to understand why is the behavior happening. Now, behavior should be specific, same as our goals. Now, if you say that a patient is just non-compliant, that is not a behavior. If a kid starts to when you say a kid is non-compliant, that is not a behavior. I want to see or want to hear that the kid is doing this. For example, the kid throws objects whenever I say this. Now, you want to identify the behavior. It needs to be specific, not tangled into emotions. So then again, it goes down first to how, or you need to know what are the causes of this behavior. Now, patient came to the clinic for pain, taking detailed assessment. I found nothing. It is due to their psychological perception. How can I tackle it? Okay. first make sure that it is really a psychological perception. Now you want to understand where does this psychological perception come from? How come there is this pain? Because a pain turned into a psychological aspect started from a real pain. Okay? Because this is where fear avoidance starts. Now, if you will track down what really causes this thinking or the psychological aspect, then we could go around it. Then again, you need to shape it. We need to let them understand that you may be feeling pain right now, but we are here to help you. And from there, we would go round by round or step by step into helping you to move again. So let them feel comfortable with a certain movement, and then it increases until they can feel less pain during the movement, or let them understand what's really happening. He had pain related back, and he always said snake bite him and all. Now, this could be a catastrophizing behavior with this snake biting and everything. Now, it's the only thing that you can do for this is to explain to them what is really happening. Then again, you don't want to speak it, you need to write it down and show it to them. Let them see. If it's a snake bite, then this would be what you're feeling. I think maybe you want to consider this one because this might be the one that's causing your pain. So this is how you need to word everything with your patient. Yeah? Did I answer your question?
Jihan,
Yes.
there is an interesting question or comment put up in the end by
Mm-hmm.
Shania. And she
Yes.
says that the patient says that the snake is biting him all the time. Now, how do you
Yes.
explain that?
Now, it depends. If the patient says that there is a snake that is biting him all the time, you want to first make sure, is there really a snake? Okay, now the key here is to let your patients realize it for themselves. Okay, you don't, every person doesn't want to be told what to do and that they are wrong. And the best way to do it is to let them realize it by themselves. For example, if they say, I have back pain and I think it's always because a snake bites me. Okay, can you tell me more about this snake bite? So you want to dig into first what is really going on. Okay, tell me about the snake bite. What were you doing before the snake bit you? Where is the snake? And then eventually, as you go on to your interview, you can now find out what really causes the pain. And the patient, then again, will also realize. You can say, oh, maybe when you reach for the snake, you did this. And then he will tell the real, yes, I did bend down during that moment. And that's where my back started hurt. So that is how you should go around it with these types of patients.
Now, is there any room for uh, calling it as a perceptual disorder and thinking about the medical management as well for such kind of patient?
Well, if it is, now you want to make sure before going into the medical referral is what type of pain are you feeling? Is it really psychological or not? And if yes, and you already done all of this and you think that it is only a problem with the sensory feeling, then yes, you need to refer it, of course, to the doctor and have them take medications for it.
Good morning, ma'am. Uh, uh,
Yes?
Hello.
Yes,
Ma'am,
I.
that snake bite was his history before 10 years. He was working for the farm for a farm or something, and there he got a snake bite, and that history is going into his mind continuously while doing his exercises.
Oh,
He can't means do SLR also. If we go for an passive SLR, then also he is only saying that I got a snake bite, I got a snake bite. That was the
oh.
real thing.
I see, I see. So with this patient, if they keep on blaming it to that first scenario, what you want to do now is to have an interview. You just say, okay, I understand you had a snake bite years ago, but let us talk about what happened before you feel that again. It could be related to the snake bite because you don't want to discredit that because it would make your patient aversive to you. It could be related to the snake bite, but I want to learn or I want to know what happened before the recent thing occurred. So you might brush it off. Nothing. I just sit down and do this and do that, and you just do your deductions from it.
Thank you, ma'am.
Yes, you're welcome. Color therapy helps to behavior change. Yes, if in terms of pediatrics, if the color reinforcing for the kid, then yes, it could help change the behavior. Now, it's always something to do with the reinforcement. Anything. It could be a chip, it could be a song, it could be colors. Anything that could be reinforcing for a kid can always change a behavior. We come across patients who think that only modalities are beneficial for them, and they think that if we do not use modalities, their problem will not be treated, even if we do exercises so that we can, okay. Now, this is also common. If your patient thinks that modalities are the only thing that are beneficial, it's okay. You don't need to change that. Now, what you want to change is for them to start exercising. Remember that if your patient believes that something is helping them, you don't want to discredit that, okay? Because you might just create like a negative pattern of behavior from that. So what is your goal here? If your goal is you want your patients to do exercises, then just say, yes, I know that yes, modalities are really beneficial, but you know, if we add exercises, then your healing process could be faster. And then from there, now you shape them. How about we just do 10 push-ups today, or like 10 curl-ups? And then now they will feel good if they're feeling or being able to do something. This is rewarding for them. If you take something that they cannot do before and show them that now you can do it because of the exercise, then again, they'll start doing their exercise. You need to let them understand what are they gaining from this, because you cannot just change it abruptly. Yeah. How can I use the behavioral therapy for geriatric patients? Because many of them at the age have an old set mind. Okay, Johar. Now, you need to tell me more about this old set mind. What are you trying to change from here? What do you mean by this? Yeah. Where's Johar? Yeah. Commonly feel exercises aren't important at that age. Okay, same thing. If you think that your patient doesn't feel exercise is important, it's okay. Leave it be. What you want to do now, regardless of what they think, you want to make sure you get what you want. And that is for them to exercise. Now, what is the best thing to do? Change your motivating operation. Change the environment. Meaning, make your exercises fun. Geriatrics tends to have a child set of mind again. Now, if you want to do is to help them exercise again, integrate each exercise that you know into something functional in their daily life. For example, start doing pass the ball with a weighted ball, or start doing races, or make everything into play, or into something that they are motivated into. And by this, then again, make them dance, because your goal is for them to exercise. So if you change your environment and your motivating operation and you reinforce this, then you could have them change and you can have them exercise as you like. Yep. How to modify a negative behavior of a child? So, Rupa, what do you mean by a negative behavior? What does the kid do? You need to be specific. Does the kid throw a tantrum? Do they throw? Do they bite? Do they kick? Do they spit? So what are we trying to change? And why is this happening? What happens before this? You could unmute your mic, yeah, so that we could talk.
See his message.
Yeah. Okay. Many times child used to be angry in some conditions. Again, angry is not a behavior. We need to know what is angry. Throwing, kicking, spitting, shouting, whining, crying. Now these are behaviors. Now saying it's angry is an emotion. It is not a behavior. How can you say he's angry? Maybe he's upset, or maybe he wants something. So what's happening here? All right. Now, let's say, given for example, that your child used to throw things whenever you give them. Now you want to understand, why is my kid throwing this thing? What happens because throwing? Did you ask them to do something? Right? Now you want to change the antecedent. Okay? Now, if you find out what is causing this, you want to change that. All right? And if you change that, then you could have a treatment for them.
Jihan,
Yes?
I'm not sure, but I use this trick. Sometimes I just talk to the patient and I ask, okay, so you tell me why you got this problem. That's the first
Yes?
question. Then
Yes.
second question I ask is like, so what do you think is the diagnosis? Sometimes, the patient says, oh, are you asking crazy question? You're expert, you should know. But then, some of them, whatever they have in their head, they keep telling
Yes.
that, okay, I think I had this diagnosis. Then I ask, okay, why you got this problem? And then like we had that patient with a snake bite. Likewise, sometimes the patient says, okay, I think there is a less circulation in that part of my body. Likewise, you come across funny things. And then I
Mm-hmm.
ask the last question, so tell me, what is the best treatment for you? And
Mm-hmm.
then there comes that vigilance question, that patient has something in the mind that I should use
Mm-hmm.
this machine or modality, and if I don't use that, the patient is not happy. But then how will I come to know what the patient wants it? So sometimes I ask this silly question like, okay, tell me what is best treatment.
Okay. Now that's okay, but the thing is that the thing is we should remember that the patient comes into us to seek consult because they don't know what's happening to them. Now, if we ask these types of series of questions, they might think that you don't know what you're talking about, and that's not really something that we want. They might think, "Oh, this is silly." Of course, they will answer you, but we want to just rephrase it, but getting the same answer. When the patient comes into you and you say, "Okay, what brought you here?" instead of saying that, what do you think your problem is? So when you say, what brought you here? The patient will say, oh, I was here because I think I have this thing. And because this is what's happening to me. So it's just the right usage of words. After saying that, okay, what brought you here? All right, I think that could be a problem. How did you find out about this diagnosis? Or have you Googled any so far? Because pretty sure your patients really Googled everything. And when they say, yeah, yeah, I searched it into Google. Okay, so now you have an idea. Maybe he's just taking all of this psychologically from the things that he read or so on. What is the next step? Now you want to affirm what they're feeling. You would say, okay, I understand that now you're feeling this and it might be what you have searched, but we need to do more testing and diagnosis for it. So that now they know that, oh, he's an expert. He knows he's going to test me for this. And after that, now you go on and giving a diagnosis. And now you would say, what is, I think you won't ask them what is the treatment you think it is because you are in position to tell them what it is. So you tell them, the best thing that we can do for now, and I need your cooperation with this, is to have this done, whatever your treatment plan is, explaining them what would be the benefit of doing this. Now, in order to deduce if it's just psychological or not, this is where you have your assessment test, your special test, you have your malingering test, you have your passive range of motion, and different kinds of outcome-based assessments. And from this, what you can do is now you can deduce. So we use an OS3 back scale, of course, for the back pain, and we have the psychological questions from there. And one thing that is good to use to know whether it's psychological or not is your ICD, ICF, RTS form. There is a clinical checklist for physiotherapists there. And there are questions there were, and you can see that, oh, if the question is all no, then the patient is just saying it's all in his mind. So we want to take the pattern of the motion and the psychological aspect. Does it tally to itself? So did I answer the question? Yeah?
Yeah, yeah.
Okay. Many times happen that geriatric persons pretend to sleep whenever it's their time to do their exercise. What should we do? How can we know that they're pretending or it's due to heavy dose of medicine? Because generally the relatives, they are doing okay. Now, if you just want to differentiate whether it's because of the medicine or they're really sleepy, you must learn what the medicine is. I am a physio and I study the pharmaceutical, what are the side effects, what is the dosage that can make them this and that, just to know how I can go about my treatment. Now, if your patient pretends to be sleeping, whenever you catch a moment that you can have a therapy, make sure that your therapy is so fun that they will look forward into it. Again, change your motivating operations. Make them motivated to do it. Know what your patient likes. If your patient is a previous golfer or a previous cricket player, you want to shape your treatment program into this types of therapy. It doesn't need to be boring. It doesn't need to be doing bicep curls all the time or jogging or marching or running. Put it into play therapy. Treat your geriatrics like your pediatrics. Because then again, they are tired. And why would they need to do it? I'm old. I'm going to die soon anyway. So treat your geriatrics like your pediatrics. Make them fun. Recommend Weddell sign as a routine tool to assess malinger patients. Well, it's not bad to use it. It could be an added data, of course, but you could always use different types of assessment tools for that. Yeah, you could always, you could use it. Final year student, whenever condition about which are you study, I think that I might have that condition because many of the symptoms match. So can you let me know how can I prevent thinking about that I may have this disorder? Okay. I understand that is the nature of human being thinking because what happens is it becomes psychological. Now, what happens or what's the best thing that you can do is avoid looking into this thing. If you feel a cough and you know all of the differential diagnosis from a cough, stop doing that. You're not a cardiopulmonary doctor, okay? Now, what you can do for this is if you are not well versed to deduce everything, you might want not to catastrophize. This is an example of a catastrophizing behavior, okay? And what you want to do is a preventive thing. Remove the antecedent, okay? Remove the antecedent. Why are you looking into this differential diagnosis? Why are you looking up into Google for all of this? Now, if you want to prevent them from thinking this is a self thing that you could do, no therapist can help you do it because this is a self-motivating thing. Now, instead of thinking what is happening with you, you need to do about it. You need to do something about it. If you feel knee pain, instead of thinking maybe I might have cancer in the bone, just treat the knee pain. What is causing the knee pain? Unless you have the symptoms of cancer. All right? So we don't want to be diagnosis oriented. We want to be symptom oriented. Treat the symptoms. Never mind the diagnosis. Diagnosis is important, but treat the symptoms. Then go with the diagnosis, especially if it needs medical help. Yeah? Did I answer your question, Kumar? Okay. You're welcome. If you want guys to learn more about behavior therapy, we have, I think there is a website, it's called Behavior University, wherein it's just a 40-hour course and they will explain all about applied behavioral analysis. And from there, you could understand it more in depth because there are a lot more than what we have tackled about today. So I could just give you guys the website and you can just look up into it by yourself. 4 years old kid, when I make him to do exercise, he ignores to do such exercise. And he didn't do exercises. Okay. Now the thing is that let's jot down the antecedents, the behavior, and the consequences of this case. You have 4-year-old old and you make him do the exercise, and he ignores the exercise, and now he doesn't do the exercise. What is the antecedent? Antecedent is you asking him to do the exercise. The behavior is ignoring the exercise. And this is the most important one. What is the consequence? You stop giving the exercise. Now, if the patient sees that whenever he ignores you, he can escape the exercise, then he will continuously do or continuously ignore you. So if your patient ignores you, don't make it an excuse to stop the exercise. Continue the exercise. Now, it's a 4-year-old kid. What kind of exercise are you giving? Is it in play therapy? If it's in play therapy, make sure that your kid wants what you're doing. Right? Maybe he wants a ball, but you're giving him a bolster. Or he wants a bolster and you're giving him a ball. Integrate what he wants. What is reinforcing for this kid? And whenever he does the exercise, reinforce him. Give him something that he wants as a reward. We always use a reward system still here. So if the patient gets what he wants through reward system or through enjoying the therapy itself, then you could help the situation. Again, just jot down what happened before, what is the behavior, and what is the consequence. What does he get from doing all of this that he keeps on doing it? And for this manner, it's because he stopped the exercise. That's why he continues to ignore it. Yep. I gave him generous play therapy, but then he also ignores such as because he has to do, except because he has to do it by himself. Okay, now I want you to go back to your goals. Now, what is the goal? What is your goal for the patient? Can you achieve this same of goals in a different style? Get out of the box. Now, if you want the kid to, for example, strengthen his arm and raise his arm, instead of doing it into like ask him to reach a ball up, tada, he raises his arm. Now, don't make it instructive, although I understand it is in play therapy. We just want to make sure that he enjoys it. Because pretty sure if the kid enjoys the play, then he would do it, right? And because he has to do it by himself, you need to give him more reinforcers. If he does something like go yay and go give him everything that he wants for that specific moment. So that now he'll learn that if I do this by myself, I get a reward. Right? So did I answer your question? Sometimes he got overexcited. Oh, what is the problem with overexcitement? I think it's fine. It's a kid. Let him be overexcited. It's not something that you really want to address unless it's harmful to him. Yeah? If you get overexcited, use it as a tool. Make everything that you can do at that moment will make excited. You're welcome. Are there a question?
I think we finished questions. So
Yeah.
Jill, you can continue.
Yes,
Vidya madam wants to speak something. Vidya madam has a question, I think.
Okay.
There's one more question, I think.
Okay. Sure.
No, sir. I means my all questions are clear. Thank you so much, ma'am.
You're welcome.
My all doubts are clear. Thank you so much, ma'am. Jill, now you can continue.
yes, ma'am. So thank you so much, ma'am, for enlightening us with your knowledge. I'm pretty sure that this information that you gave us will help all of us and will be very beneficial for all of us. So now I would like to call upon Udra to give vote of thanks. Over to you, Udra.
Thank you, Chief, and a very good afternoon to one and all. Honorable dignitaries and all the participants, I am Urja Vaidya from Final Year BPT, and it's my privilege to propose vote of thanks in this webinar session. On the behalf of Nutan College of Physiotherapy, a constituent unit of Thakachan Patel University, Visnagar, I express our sincere gratitude to Dr.Jihan Sokkary ma'am for sharing her valuable knowledge with all of us. I'm also grateful to respected Vice Chancellor Dr. Professor V.K. Srivastava sir for providing us encouragement. I'm also thankful to Faculty Dean Dr. J.R. Patel sir for always keeping us motivated. I would like to thank our President Shri Prakash Patel sir, who is the backbone of Thakachan Patel University, for all his logistical support and encouragement. I wish to thank our Principal Dr. Subhash Khatri sir for his guidance and support. I must mention a deep sense of appreciation for Secretary Dr. Vidya Rajput ma'am for all logistical support and help. I'm grateful to our team members and all the faculty members for their direct and indirect support in organizing this webinar. Last but not the least, I would like to acknowledge all the participants for listening with patience. Finally, acknowledge each one of you and declare that our 3-day session is over. Thank you.
Thank you, Udra. Now I am signing off here as Master of Ceremony and also declare that this webinar series is over. So see you all next time. Until then, goodbye and have a nice day.
Thank you, Jihan madam, and goodbye.